Hi, today we're going to talk about types of insulins, and we're going to talk about onset, peak, and duration of insulins, and some common orders that we utilize for medical management diabetes. So let's start with the short and fast acting insulin. Its onset is between 15, 20 to 30 minutes. Sometimes it can take a little bit longer, but that's about in general. Its peak is around 2 to 4 hours. And then the duration's between 5 and 8 hours. And so that is the fast acting or short acting are commonly used for medical management with a sliding scale or a scheduled or an insulin to carb ratio. So let's talk about the sliding scale. So the sliding scale, again, we use Novologapedra, Lispro, faster acting insulins. And so the sliding scale is utilized to correct what the blood sugar result is. So we'll find what the blood sugar result is and a correlation of whether we're going to do mild, moderate, or aggressive correction on that patient. So we would be providing an amount of insulin to make available in the vascular system to be able to utilize the glucose or pull the glucose from the vascular system. The cells are able to utilize the glucose to function and lower the glucose in the vascular system. So again, a sliding scale or a correction of what the blood sugar is works very well in the hospital for a short period of time. And then of course the goal is to determine what this person's insulin needs are and get them onto a combination of insulins that would similarly mimic what the pancreas may not be doing at this point in time. So again, the sliding scale, we call it a correction, but a correction would mean that we're allowing the blood glucose to become elevated and out of the target blood sugar ranges. So we are aware the CDC states that a blood glucose greater than 152 can put a person at risk for surgical site infections or poor wound healing. Also, when blood sugars reach about 170, the kidneys will start to diurese and urinate out extra glucose, but then also it can cause electrolyte imbalance. It's going to take the sodium potassium with it, so we may have electrolyte imbalances and abnormal ranges also. So again, the goal is to keep the blood sugar above 80 and less than 180 post-meal without too many big peaks out of those numbers. So the sliding scale works very well for a short period of time while we're determining how much insulin someone would require. The sliding scale works very well for insulin resistance also. When someone's on a prednisone, a steroid, they have an infection, inflammation, stress, and so again, we're providing a correction for that blood glucose level. And then also the sliding scale might be utilized, and you might see something called scheduled insulin. So the scheduled insulin is providing a set amount of insulin for the meal that a person's about to eat, and that's really considered an insulin to carb ratio. There's some general guidelines for that. It might be 1 unit for every 10 grams of carbohydrates. Sometimes we might do 1 unit for every 20 grams of carbohydrates. So a lot of times you might notice where someone has 4 units or 5 or 6 units with each meal, we're assuming that that person's going to take in at least 45 grams of carbohydrates, or a full meal might be up to 50 to 60 grams of carbohydrates. So again, we're providing a faster acting insulin that gets into the blood, and it's available for when that person eats the food. The glucose is broken down into glucose in the vascular system. That mealtime insulin is available, the cells are able to use the glucose, and the blood glucose returns after that meal. Less than 180 is pretty much the goal. And that is a really good way to determine if a person is on a good insulin to carb ratio. So again, the schedule would be for the food they're eating, and the sliding scale correction would be an extra amount of insulin providing what the blood glucose is at that point in time. Hopefully we can, after the insulin resistance, the infection, electrolytes, gestational hormone is corrected, or the prednisone, then we can get them on a scheduled amount of insulin. Another good common combination of insulin is a long-acting insulin. And long-acting insulins have a slight peak at about 8, but it really is pretty much steady. And many of the long-acting insulins work 12, 24, even up to, we have some that work up to 46 hours. So there's Levemir, Lantus, Basal, Soliqua, and some other new long-acting insulins. And so again, there's just a basal amount of insulin that's available in the vascular system for that person for 24 hours. So that's just kind of a basal amount. And some of those people are actually making a small amount of insulin. So when they're eating food, their blood glucose may correct on its own, and then they have that hovering basal dose available. So it's important to make sure that our patients are aware that they are not on a low carb diet. They are on a consistent carb meal plan. And so that again is at least 45 grams of carbohydrates per meal. If they're not eating, they might require a supplement or snacks in between. If they have some slow digestion, they might need small frequent meals to ensure that there's a steady amount of glucose in along with those insulin doses. Another common insulin that we see utilized is NPH. It's an intermediate insulin, and that works onset around 1 to 3 hours, and it peaks about 8, and it is durations around 12 hours. It can be up to 16, 8 to 16, 12 hours. So a lot of patients are put on that so that they have fewer injections required, so they can take 2 injections a day and have enough of insulin available throughout the day and in between meals. Sometimes that's unpredictable, and if a person is not eating during a peak period, they may have an event of hypoglycemia. NPH is often utilized in gestational diabetes, and so that is provided during the gestational insulin resistant period of time to try and keep the blood glucose levels in target ranges. And for gestational patients, their blood glucose levels are a little bit tighter than in general guidelines, and that is provided by their primary care OB physician on what those tight blood glucose ranges are. But post-meal is quite a bit tighter during gestational diabetes than the post-meal less than 180. So I think there's around 120 to 140, and prior meal there is going to be closer to 90 instead of 80 to 130. Again, we're talking about trying to keep the vascular system between target ranges so that our red blood cells are healthy. So really thinking about that, the red blood cells circulate in the vascular supply 90 to 120 days. And so any unused glucose can tend to bind to that red blood cell, causing a glycemic coating on the red blood cell, which then may impair that red blood cell to be able to pick up oxygen to it and to circulate through the microvessels, our eyes, our kidneys, and to carry oxygen into the tissue to keep it healthy, to heal properly, and transport oxygen into the tissues and organs. So again, the goal is to keep the blood sugar in tighter ranges to keep our red blood cells healthy. So it's a vascular disease that can complicate or cause poor wound healing, organ damage, and risk for stroke and heart attack just by not keeping those blood glucose in tighter ranges. So that's really the goal of insulin therapy on our patient population, and then providing them the education so that they understand that food and insulin actually go together. And that is really part of the education that we need to provide for our patient population. I hope that that was helpful.